I was in school, I was like, okay, I knew there was two things I was not going to do. Y'all may have heard this. Like, I'm not going to go to women's health. Yeah. I'm not going to go to pediatrics. Like, two things I knew. I want to take care of, I want to do like internal med, old people. Then I got to spend some time in orthopedic surgery, and actually, my favorite patients in orthopedic surgery were the kids. I loved treating the kids. Why is it fun to treat kids? They want to get better. There's no secondary gain. They're, they heal like gangbusters. I mean, they just, they're highly motivated to get back to what they want to do. So I did come around, kind of in the middle of my PA career. Like, I do like taking care of kids, but it was a long time coming to that. So this lecture is just to kind of give you an overview on like the most common things you're going to see, and touch on, you're going to be touching on a lot of these questions on board exams, because they love those old dead guy names. So one thing you guys, I'm introducing for lab med in this lecture is how to analyze joint fluid. Okay, did y'all go over that a little bit in musculoskeletal, like crystals? So we're going to talk about septic joint, and so we'll talk about it here in a minute. But you guys need to know how to interpret that lab. There will be questions on it, so just be comfortable with how to interpret that. The other thing you guys would have to be able to do is interpret x-rays and tell me what kind of fracture it is as far as how to grade it with Salter-Harris. Okay? I know that's been introduced to you at least once or twice in musculoskeletal, but hopefully I'm going to help clear some of that up hopefully in this lecture, so you'll be able to interpret those x-rays, because that's growth plate injuries are, you need to be able to recognize them. Okay. So this is just kind of an outline of what we're going to talk about today. We're going to learn how to work up the limping child, what's your differential diagnosis, and a child that comes in limping. We're going to talk about Auschwitz slaughter, nursemaids. You guys have already had a little bit of nursemaids, so we won't spend a lot of time on that. We won't spend a lot of time on scoliosis. And you've already heard osteogenesis imperfecta. We'll briefly go over that. And then the two bone cancers. I know you had a lecture yesterday. They talk about osteosarcoma in Ewing's a little bit. Okay, we're going to look at them on x-ray. And then, of course, really important is those Salter-Harris classifications. Okay. I hate these slides. That's what you need to do when you evaluate a pediatric musculoskeletal complaint. Watch them walk. We've learned pelvic tilt, Trendelenburg. We're going to look at different gaits. Has anybody looked at the abnormal gaits on D2L yet? There's little snippets of videos that you can just watch to see what the gait looks like in a kid. Put your hand on the joint that's sore, feel for warmth, look for swelling. If a kid comes in with a knee complaint, what signs are you going to see if it's septic? Warmth, redness. The kid's going to be sick. Don't miss a septic joint in a kid, please, ever. Okay. And if you think it might be, send them for an ultrasound guided aspiration. I mean, just analyze the fluid if you're not 100% sure. Okay. We'll talk about that in 1 minute. Leg lengths. What are the best ways to measure leg lengths in kids? Okay. Look at their ankles, have them bend their knees, see if they're lazy, see if one knee sits higher than the other. We'll look at pictures on that. And then we'll talk about, you haven't had your well-child exam lecture yet, so we haven't talked about hip dysplasia test yet, right, at all, so we'll talk about those today. Okay. Cost-wise, save money if you'll get an x-ray. Don't send everybody for an MRI. Look at the cost difference. So hopefully I'm going to help you guys be comfortable with looking at x-rays of hips here in a minute. Okay, so first let's talk about joint aspiration, okay, because this is the lab medicine stuff I want you to know. When you suspect when you have a limping child, and we'll talk about this in more detail in a minute, but let's just talk about joint aspiration in and of itself right now. If you have a limping child with a swollen knee, if it's red, if it's hot, if it's more inflamed, the kid's febrile, draw some fluid off of it, okay? If you don't feel comfortable, get them to somebody who can immediately, like the emergency room, okay? If you're in a clinic somewhere and you think, oh my gosh, I can't aspirate this joint myself. This kid has 103-degree fever, limping, won't weight bear on that leg, looks toxic, looks sick, send them. Just, if you cannot handle it in your primary care clinic or your urgent care clinic, send them to the emergency room. There's nothing wrong with that. Emergency room doctors hate it, but if you're not able to tap the joint and get them answered and you feel like the kid needs IV antibiotics, send them, okay? We'll talk about that more in a minute. What are you looking for when you're pulling fluid off that knee? Okay, that's what joint fluid should kind of look like. I mean, that's pretty normal looking joint fluid. Kind of straw colored, but not opaque. Clear yellow, that's a swollen knee, that doesn't look infected. But again, send it for culture, send it for a gram stain. They'll count the white blood cells, they'll give you all this information you need. This is how you would do an ultrasound guided joint aspiration. They just put the probe right there and make sure that they're in the joint. It's super fancy, but totally unnecessary if you're good at sticking needles in joints. Especially if it's swollen, just want to put a needle in there and get some fluid off. You know, but you can do it with ultrasound guidance to help. And especially would be helpful in a kid. You know, the little joints are tiny. All right, you need to know this table. So again, that color you saw on the prior slide was kind of a transparent clear to yellow color. It looked just kind of like a non-inflammatory effusion. Most of the time those are going to be osteoarthritis. You're not going to have a lot of white blood cells in it, less than 2,000. You're not going to have a lot of polymorphonuclear cells, whatever PM is. And of course your culture is going to be negative. Probably wouldn't even culture it, the lab would. But you can order these with just send it for a culture. You'd rather not grow anything than not order the culture. So just culture it. When you're looking at like arthritis in children, where it's inflammatory arthritis, like rheumatoid arthritis in kids, we call that now juvenile idiopathic arthritis. You're going to see a lot more white blood cells. You're going to see those PMNs are in the 50 to 75% range, but again, the culture is going to be negative. This is the one you don't want to miss, septic joint, okay? It's going to look like pus coming out of it. It won't be clear. You're going to, when you get your culture back, it's going to be, 75, sometimes upward, 100% PMNs, 100,000 white blood cells, and of course your culture is going to be positive. So get comfortable with, this one's pretty easy to diagnose. This will be where you're like, oh, is it that, is it that? How many white blood cells is in it? How many PMNs? Okay. They formerly would do glucose and protein and use that, but it's not really even needed now. You can basically get your answer off of the white blood cell count and the percentage of PMNs. Okay. Why does glucose go down? It's the same as like if you're tapping, like if you're doing a lumbar puncture. Bacteria. Right. The bacteria use the sugar. So the glucose, normal level of glucose goes down, and you're going to have extra protein in it because you have bacteria in it. So, but if your culture's positive and you have a ton of white blood cells, you don't even really need to look at that. You've already got your answer. And then hemorrhagic ones are easy because they come out and they look bloody. And then when you get your white blood cell count back, it won't be elevated. Anybody have questions on this? It's just a matter of memorizing those numbers.
What was PMNs again? Sorry, I missed that.
It is neutrophils, basically. Yeah. Okay. just a sign that there's an acute bacterial infection. All right. Who has looked at a FLK before and wondered if that walk is normal or not? Does everybody know what an FLK is? Kid. Yeah. So you will undoubtedly, if not from a patient, you're going to get it from a family member or friend. Say, my kid, why does he walk like that? Is that normal? You're going to get asked that. Some of you may have already been asked once you were through your musculoskeletal. They're like, you're an expert now, right? So, but kids walk funny. Kids go through stages of changing their gait. So we're going to kind of talk about those. Toe walking, who has seen a little toddler walking around on their toes? I mean, that's normal. Up to 18 months, I mean, after 2, or normal up to 3, but you're at 2 to 3 years, you shouldn't be doing that anymore, okay? If your friend comes to you and says, is my kid abnormal, don't call it until they're over 3, 4, 5, and they're still walking around on their toes. My son played baseball with a kid that's 10 years old and toe walked. I mean, he had to have heel contractures. So when kids do that compulsively and they walk around like this all the time, well, what happens to their Achilles tendon? It gets shortened. Now, kids can have congenitally shortened Achilles tendons. But you can actually, from walking around like that, perpetuate that problem. You actually get to where their Achilles are shorter because they walk around like that, and it just kind of it goes in a circle. Definitely kids with CP will have heel contractures, and then again, you can just be born that way. Muscular dystrophy is one. If you see a kid walking around on their tiptoes and they have these like massively huge calves, that kid probably has muscular dystrophy. So you may see that at the playground someday when you're watching your kids play. They'll have pelvic girdle weakness, and they'll have these like no quads or hamstrings, they'll have these huge calves, and they'll walk around the playground like that. Like that kid's got muscular dystrophy. So there is an old story about that the orthopedic surgeon that I worked with, that like at OU in like resident ortho clinic, they would just cut heel cords in the office. They'd just get a scalpel and hold the kid down and get rid of the heel contracture. Basically, just a level right there. I think that's frowned upon now. They're like, oh, the old doctors would be like, oh, it's more of a fuss to put them under anesthesia, and it only takes 1 second. It's like me with a hemorrhoid. I'm like, oh, just do it. Don't even anesthetize it. They're like, oh, it's more of a fuss to bring them in, schedule surgery, bring them in the OR, anesthetize them. It takes 1 swipe of a scalpel to cut their heel cord. So, interesting. So, what my point for this is if you're in your clinic and this mom wants you to assess their kid's perpetual toe walking, check their ankle range of motion, see if their Achilles are tight, and if there seems to be an Achilles contracture, send them. They probably won't cut it in the office, but send them to an orthopedist. So everybody's seen a cute little bow-legged baby, right, as they start to walk. Most have a bit of varus to their knees. That's normal. Again, that's going to be normal up to about 2 years. And this is a wide range. I'm not going to hold you down to testing you on up to 2 years. This is normal. I mean, there's a spectrum of what's normal. But if you're getting beyond 2 years of age, it's not as normal anymore to have varus, bow-legged knees. By the time they get a little bit older, they straighten back up. Okay, so somewhere around 1.5 years, they straighten back up. Then, between 2 and 3 years, they tend to get a bit of knock knee. And then that's where you'll see those parents worrying about their kids toeing in. They'll kind of be, or they might trip over their own feet because they'll turn their toes in. But that's normal in that 2 to 6 age. Okay. Again, you have to get comfortable with telling parents, You know, that's expected. That's normal. It's normal for kids to go through that change in their pattern of how they walk. Let's watch it, you know. And then again, somewhere by the time they're 6, they usually straighten back up again. Okay? They start out in varus, they straighten up, and they go to valgus, and then they straighten up again. So just know what's normal when, okay? Everybody knows what an antalgic gait is, correct? A limp on a sore extremity, ankle sprain, tore my meniscus, okay? If you see a kid walking with an antalgic gait, you're thinking, okay, he's hurt himself. Did he fall down? Did he fall off the swing set? Did he twist his knee? Did it happen in sports? If not, then you have to rule out a septic joint at that point. You need to be thinking, could there be an infected joint somewhere? Okay. If they're walking with a Trendelenburg gait, they've got a hip problem. Okay, does everybody remember Trendelenburg sign? Does everybody remember Trendelenburg gait? They'll just kind of kick their pelvis will kind of tilt. Does it tilt towards the affected hip or away from which side tilts? Away. So if you've got weak glutes in your right hip, the glute medius is weak. When you put your weight on that, they fail. So you actually, it's the unaffected side that dips. That can be confusing. But if you think about it being glute weakness, when if you have to fire your glutes, you step on it, that's when it's weak, that's when it gives out. So their pelvis will kind of swing towards the bad hip. Okay. And it gets bad enough their whole shoulder will drop on the opposite side. Okay. And again, you can watch those videos. If you have time, we'll pull them up. But they're on D2L. If it's bilateral, they've got bilateral hip dysplasia. They'll waddle. They'll dip on both sides and be waddling through your office. There's a good video on one of those where a little girl with bilateral hip dysplasia. Okay, circumduction gait. Everybody know what that is? So I think who's seen The Theory of Everything? It's how he walks early, why he trips over his foot and face plants. Is it Cambridge? So they swing their foot. They'll have a foot drop, and so they'll swing it around. That can be, again, it could be a foot drop from a neuropathy, like Stephen Hawking had, or a stroke, like a kid that had an intrauterine stroke or something. They'll just kind of swing that leg around. Okay, because they can't pick their toe up, so they'll have to swing it out. You all have a mental picture of a kid or a person like that. Think stroke victim. They'll hold that arm in and swing that leg out. Equinus gait. There's some good videos of Equinus gaits. These are definitely from toe walking for too long, heel contractures. They basically walk and they look like a little prancing pony, because they've got both of their toes down. But you can watch those. That's why they call it that, because it just looks like the front feet of a prancing horse, Okay. Any question about gaits? You all feel comfortable if you have a mom come in and say, PA, tell me, does my kid have something wrong with them? You're like, oh, I feel totally confident to. Now you'll have to look it up again. Okay, so Dr. McNeil being the outstanding anatomy teacher, yes?
Sorry, I'm being
Okay.
On the limping child slide, is it supposed to be hemiplegic or is it? Go back.
I don't know.
No, there's a spelling. I don't know if there's a spelling error or if
I'll go over spelling errors at the end of the lecture if you can't figure it out. So, back to hip anatomy. So, the he taught you guys about the ligamentum teres, right? The vessels come in, which makes the hip susceptible to what? Right? Did everybody hear that? Avascular necrosis. Because your epiphysis is fed by the little teeny arteries that come in through the ligamentum teres. And in a small subset of population of people, which is like boys ages 4 to 5 years, some boys, 4 to 5 years old, that's not fully developed for a long time. I mean, you have a span of about 4 years where you're getting all of your blood flow from here. And so if any tiny bit of insult happens to those vessels, that epiphysis will not be able to turn bone over, and that head will start to collapse. We'll talk about that here in a minute. I want you guys to be comfortable with knowing the difference between an epiphysis, a physis, and a metaphysis. Everybody feel comfortable with that? Okay. So the physis is the fancy word for growth plate. Okay. So in the femur, it comes right across the neck. Okay, which is already kind of a weak spot anyways. So the physis is in the exact same place where you can get femoral neck fractures in the hip. The epiphysis is the top, and then the metaphysis, the longer part of the bone, below the growth plate. To start out thinking about a limping child, you've got to think about hips in a limping child, okay? Especially if you see a child walking with Trendelenburg, right? You see him kind of dipping. And you'll get so good, you'll see him walk in the clinic and be like, that kid's got a hip problem. So once you see a limping kid, and you see, and maybe they have Trendelenburg Gait, they, just based on the age of the kid, you can start to build your differential, okay? So if the kid's less than 4, or let's say less than 2, it is septic, it's a septic hip until you can rule that out for sure. And you can rule it out with a history. I mean, does the kid look really sick? Are they febrile? Are they refusing to walk? You know, have they had some other illness going on? But think about that. I want you to always think about it. Could be septic. Okay. The age of about 4 to 10, it's septic arthritis is a little bit less likely. Now you've got to think about Perthes disease, which we'll talk about in a minute. And again, you guys can reference this chart back once we get through all of these topics. If they're older than 10, if they're adolescent, then you kind of bring into your differential slip capital femoral epiphysis, okay, or Skippy. Did y'all talk about that in anatomy? Okay. So, just like again, limping kid, think about the age, and then assess whether they're sick or not. Or is this a sick febrile kid? And all these uncommon things, you need to kind of have it in the back of your mind that there could be something bad going on, but it's a lot less likely. What's the other thing you have to think about if they're younger than 4, which I don't even like to talk about? Are y'all going to have a lecture on child abuse? So, what kinds of fractures are there? Are they the spiral fractures from jerking kids? So, limping kid, if you think this family looks shady, I don't like the vibe in the room, there's bruises everywhere, a bunch of bruises of a bunch of different ages all over the body, you need an x-ray of the femur, for sure. Get the whole femur, because they could have a femur fracture from being abused. Okay, common cause of limb pain in children is growing pains. How do you know if it's a growing pain? How many people's parents have said, "Oh, you're just having growing pains"? I mean, it's common. it is never going to be in a joint. It is non-articular, okay? They're not gonna say, oh, my knee hurts, oh, my ankle hurts. They're gonna hurt, usually it's in the shin. It's in the long bones usually. Their thigh hurts or their shin hurts. It's not in a joint. It's almost always bilateral. And it comes and goes for no apparent reason, and it often wakes them up at night. Okay? But what's the other thing that can wake the kid up at night? With bone pain? Cancer, right? That if they're hurting in both legs, and it just kind of comes and goes sporadically, then it's probably growing pain. It's probably not cancer, but if you're not sure, x-ray it, okay? There's usually not any associated limping, which there is with cancer, and there's usually not any limitation in the motion of the joint. Like again, it usually doesn't affect the joint at all. And your treatment for growing pains, tincture of time, wait it out, reassure mom. But if it persists and she brings them back in, get the x-ray. Okay. So our first big topic is developmental dysplasia of the hip. It used to be called congenital hip dysplasia, but they changed the name because yes, it's congenital, but you sometimes don't even develop it till later. Like you're born with the propensity to have an unstable hip, but it may not become apparent until the kid starts weight bearing or starts demanding more of their body. So therefore the name change is more accurate to call it developmental dysplasia. Much greater in females. Oh, and I forgot. Why is this more common in males? Pain tolerance. So I don't know that to be true. I actually looked for something to help me like prove that, but I couldn't find it. But hip dysplasia is female. Okay, your typical patient is going to be a young, like really young female. Maybe they just started walking, and all of a sudden they're limping and they're walking weird, and mom's worried about it. What I want you to know about hip dysplasia is it's one of the things that you screen all newborns for, whether you think they have any risk for it or not. Okay, we'll talk about how to screen, and it's going to be part of your well child, your newborn well child check. Okay. What makes the joint unstable is not just the bone. Okay. So these hips will be unstable because, sorry, I gotta erase this. Everybody see their snacks? So if you have pelvis, and then you have an acetabulum, okay, and you have the femoral head in there, right? These kids will have their femoral head's fine, but then this really shallow socket, okay? So they just don't have this nice little rim there to kind of hold it in place. So they have that more shallow acetabulum. It's easier for that femoral head to slip out the back. And it usually will posteriorly dislocate, okay? It's more common on the left, which I find interesting because of how the baby usually curls up inside the uterus. So if you suspect this, what you'll see, lay them on the table like that. Their normal leg will just fall out in abduction, and the other leg just stops because their femoral head's not in the socket, so it won't externally rotate. Some of your risks for this are listed here. Definitely the big one is female. Somebody having had congenital hip dysplasia in the family. There are some things intrauterine that can put you at risk for oligohydramnios. That's kind of interesting to me that you have not enough fluid to kind of bounce around in the uterus. That can scrunch you down a little bit more. Yes?
Is that going to be painful?
So usually they will, the parents will notice a limp, but the kid usually doesn't complain. And that's listed here. So usually your signs and symptoms are, the parent will just notice that they're walking funny as they start walking. You tend to have a little bit more lordosis in their back because they're trying to kind of center their gravity over, because their femoral heads are in the wrong place. So you'll notice that excessive lordosis as well, waddling if it's bilateral. Definitely can shorten the leg. Why does it shorten the leg? Because the femur is behind the socket, so the affected limb will be shorter, which you're seeing there with the lazy sign. Okay, so how do you screen? Okay, this is kind of tricky. You need to know this. Before any kid is 3 months of age, you need to have screened. And most of the time, they're screening these at every well child check every time they come in. Okay, because it's really easy to do. So you do 2 maneuvers. Okay. And well, here's your two things we've already talked about already. They won't want to externally rotate and abduct. And then you can see the difference in limb length there. Kind of get those little footsies together and see if their knees are at the same height. Okay. The interesting one is they'll have more thigh folds on the short limb because the leg's longer. There's more skin and fat, and so they'll have increased number of thigh folds on the short leg. It's kind of interesting. I've never counted baby thigh folds before. I mean, maybe Professor Lovick may have. Okay, so your 2 maneuvers you need to know, Barlow and Ortolani, okay? I should have brought a baby doll today to show you this, but you can watch it on, I put a video on D2L you guys can watch. You're basically, when you do Barlow, you pull their thighs together and you actually try to dislocate it, okay? And it will, if it dislocates, it won't hurt the baby, and it'll happen very easily because, first of all, think about it. That epiphysis is mostly cartilage, okay? It's just kind of floppy in there, so you're not going to hurt the baby by just gently pushing posteriorly to see if you feel it, okay? Click or plunk out. Now here's the other catch on that. You may not feel it slip out. What if it's already out, okay? So if you don't have a positive test when you try to dislocate it, adduct their legs together and push them posteriorly. If you don't feel anything, then try to reduce it back into the joint and see if you feel it click or clunk back into the joint. Okay, and how you do that is just bring the leg out. You put your whole hand on their little leg and you just kind of try to hold and see if you feel a plunk back into the joint. Okay. The more unstable the hip is, the less pronounced the plunk's going to be. So it's not a perfect test, but you've got to know how to do it, and you got to feel a lot of normal ones. Just like any physical exam maneuver, got to feel a whole bunch of normal before you go, oh my gosh, I just felt my first positive Ortolani, you know. So do that on every baby you put hands on. Okay, borrow your sister's kids, you know, go down to the neighbors and say, can I borrow your newborn? But again, I'm just joking, that's a difficult thing to do, but when you're on rotations, you know, do that on every kid that comes in the office. Just feel if they're newborn. Feel if you can, you got to get a feel for what normal is. Normal is nothing's moving where it shouldn't be. Okay, you won't really know what it feels like until you feel the clunk. But the take home on this is you've got to do Barlow, but just because Barlow is normal doesn't mean the hip isn't displaced. You've got to try to put it back in with Ortolani. Then you can say, okay, their hip's in the socket. Okay. This is how you can remember them. below is the evil doctor that dislocates the hip. And then there's the nice Italian man that puts it back in. It's back in. So if you're, yes,
Does it affect their crawling, or do you only?
it's usually only when they start weight bearing. That's a good question though. Yeah, they don't, that's not a sign usually until they stand upright. And then it's probably with crawling, you're just kind of, you're not really putting a lot of weight on the pelvic girdle. You're kind of distributing across all 4 limbs, and so it's not as problematic. They may not even dislocate it until they stand up. You know, until they fully stand up and get all their weight on it, it goes boom, you know, and then they're walking around in their Trendelenburg. So, good question. If you aren't sure, you can x-ray it, but I would ultrasound it probably. It's probably going to be a better test for bone that's not bony yet, okay? And again, this is just kind of giving you a bit of an idea. I know it probably looks like you're looking at the face of the moon or something, but you know, you can see that hip is in the socket. You can see this one is slipping out, okay? But that's tiny. I mean, it's this little teeny tiny. That's, so you can see how that examiner could just put his hands right there and just feel if he can reduce it back in the socket. If you were to get an x-ray, this is what it would look like. Okay? It will always displace posterior, so it will kind of look high and behind. It won't go down. It's not going to lengthen their leg, it's going to shorten their leg, so it will pull it up and behind the acetabulum. And really, you're not even going to see anything until they're over 6 months of age on an x-ray. So that's where, if you're really suspecting this in a newborn, you need to get an ultrasound. Okay. And again, do your exam. You don't even need an x-ray if you've got positive exam findings, right? How do you treat it? As you'll find with a lot of these treatments for hip problems in kids, it's containment. It's containing the femoral head in the acetabulum so that the bone can remold itself and the socket can deepen and it can become more stable. Okay? So they have these fun little things that can put kids in. So I personally, if we had something like this, we referred it to a pediatric orthopedist at OU, but so I would never have to check these kids on return, but you would just follow them, probably with ultrasound, I would think, to see if the socket's deepening. Okay. Transient Synovitis. Have you guys been introduced to this at all yet? No? Okay. This is I've actually had personal experience with this. My son had this at about age 3. It's very common. It's the most common cause of limping in a child between ages 2 and 7. Okay, you will see this at some point. Family member, patient, somebody, you will see with transient synovitis. It is usually a painless limp. The mom will just notice that the kid's walking funny, and it's antalgic. It's an antalgic gait. It's not a Trendelenburg gait. Okay, they're just shifting weight off of their sore leg. And it could be in any joint. It could be in their ankle, it could be in their knee, it could be in their hip, but it's most commonly the hip. Okay. It's just transient inflammation in the joint for unknown reason. Okay, we do not know why, but it's associated with some type of preceding viral illness usually. They've had a common cold, they've had the flu, they've had the stomach bug, they've fought that off, and for some reason a week later, they're over that completely. A week later, they are limping, which is scary for parents because they think they've got, all they know is like rheumatic heart disease, rheumatic heart disease. Oh my gosh, why is my kid limping? Are they going to damage their joint? What's going on? So almost always it's this, and it goes away. Okay. There may or may not be a history of trauma. I don't like using that because if you ask a mom, well, have they tripped? Have they fallen? Have they hurt themselves? Of course they have. They're 4- and 5-year-olds, usually male, so they have fallen. So the history is probably going to be positive for some type of mild trauma. Boys are mildly injuring themselves all the time, so I don't really use that. I mean, if the mom comes in and says, my kid fell down the stairs and injured their knee, that's traumatic injury. The kid comes in limping for like really no unknown reason, I wouldn't even ask the mom unless they're telling you they hurt themselves, because they'll find something they did, but it probably is this, okay? Why does it happen 2 to 3 times more commonly in boys? I don't know. Wish I did. Same with leg calf herpes disease. It's almost always boys. So there's something anatomically different. You have to rule out the septic joint with this. How can you rule out the septic joint? Good history. Good physical exam. Put your hands on the patient, strip them down, look for redness, look for warmth. Do a good physical exam. Don't be that provider that doesn't even take the kid's clothes off and sends the mom for a $700 MRI because you didn't do a good physical exam, okay? Take the time to disrobe the kid, look at the hip, look at the knee, look at all the joints, just, if they're limping, try to figure out which leg they're limping on. And sometimes in little kids, they just won't weight bear. They may not be limping. They may just not want to bear weight on it, okay? Mom will go to put them down and they're like, they won't, pick me up, and they won't walk. Well, that's really hard because you've got to get an x-ray of something, right? So in little kids like that, they're limping. X-ray their hips, x-ray their femurs, x-ray their tibias if you have to. I mean, you get it all in one plate, you're little tiny. So just x-ray and check. If you can't get a good history, if it's just refusing to weight bear, x-ray it. Protect their little gonads, their little ovaries, and get a picture if you need to, okay? But don't let your x-ray be a replacement for a really good physical exam. You can do a really good physical exam on them. Check to see if there's dysplasia in the hip. Check to see if the limbs are short. Check to see if they have a positive Trendelenburg sign. If you do all these really good physical exams, you don't need to radiate the kid. Okay? So think about those things. How would you rule out infection? Just by looking at the kid. Is he really sick looking? Has he got fever? A septic hip the kid is going to be sick. Okay? It's almost always 2 years or younger. Okay? Are y'all getting really scared now about missing a septic joint? Good. I've done my job. Okay. So again, if you say, rather than saying, have they fallen and hurt themselves, you would be a really good clinician if you say, has he had a cold or runny nose lately? Has he had any diarrhea or any cough? Ask if they've had a recent sore throat or runny nose or ear infection. This kid if it's transient synovitis, this kid will not have fever. They will have had fever 2 weeks ago or a week ago, and they feel great now. They're running around the room, they're just limping. That's transient synovitis. Tends to be a limp that's kind of off and on, but it can get worse the more they're on it. So at the end of the day, if they do complain of pain, which isn't as common as just the limp, it'll be in the hip. Where does the hip hurt? All my students better know where the true hip pain is. It's in the front. Groin pain, proximal thigh. You're more likely to have true hip joint pain at the medial knee than you are at the lateral hip. How crazy does that sound? Okay. So I do want you always thinking, if somebody's complaining of knee pain and their knee looks completely normal, you've got to look at the hip. So if you're looking at this table, I don't know what joint it is, what the heck, you just go back to your clinical reasoning, it's almost always the hip, right? So lay them down and just log roll their leg, just kind of flex it and externally rotate it, roll it around, see if they're Bingo, got it, it's that hip, okay? And if you still aren't comfortable because you're a brand new PA, go get some fluid pulled off of it, that's fine. Don't do it in the office, out of a hip, please. Send them for an ultrasound guided aspiration, or send them to radiology at the hospital, they can do it. And then the treatment is just observation. It usually is gone within a couple of weeks. Okay? Any questions about transient synovitis? Know what age group it is, know how it presents. Know it's almost always boys. Preceding viral illness. Those are great board questions. All right, the one you do not want to miss. Okay? So, you remember I was talking about group B strep and swabbing the woman? That's actually one of the bugs that can give kids septic arthritis too. So this is going to be a sick kid. Okay, they are not going to weight bear. They are going to be laying there like that with 103 or 104 degree fever. They might have a rash. They might just have other signs of like flush skin, just sick looking kid. Okay. This is very acute. Transient synovitis comes on acutely as well. But this is like, they were fine yesterday and they are sick today. Okay? This is not an insidious onset at all. This is very acute. They will be extremely careful with that joint. They will guard it. Okay? Again, Karen will try to put them down. They will not. They will refuse to walk. Yes?
Will the transient synovitis, will it recur?
Not usually. Usually they'll have that one time, never have again. That was the case with my son. Didn't ever have a problem again. So you could actually get a CBC on this kid, maybe even in the office if you have the equipment to do it. Their white count's going to be high. Okay. Sed rate should be high. Sed rate's not a great test, really, but it should be high. And in almost half of these kids, they'll actually have blood cultures that are positive for whatever infection they have. That's why they're really sick. Okay. But if you're catching it early, you'll have to pull the joint fluid to see it. Okay. And again, going to be upwards of 100,000 white blood cell count. Okay. And your PMNs will be high on this one as well. 75% or more probably. X-ray's not really that helpful early. Like if the mom says this has been going on for 24 hours, an X-ray is not going to be that useful. The joint fluid analysis is going to be useful. Okay. Most common, you need to know most common bugs. Staph and group B are right there at the top. The rest are a few here, a few there. But the top two are going to be staph and the group B. So I find this helpful. You guys don't memorize this, but I just want you to think, thinking clinically when you're looking at a kid that's limping, and you're out there in rural Oklahoma, and you're like, oh man, I don't want to. Professor Rohr said don't miss a septic arthritis. Oh my God. You don't have to send everybody for joint fluid analysis. Look at this. If they just have one of these, 3% chance they're going to have a septic hip. But if they have two, look how much it jumps. Okay, if they're limping and they're febrile, you've got almost a 40% chance that they could have a septic arthritis somewhere. Okay, if they've got fever, they won't weight bear, and you get a white count in the office and it's 15,000, they've got a septic joint somewhere. Okay, so I find this very helpful when because you're going to be out there by yourself someday. Just think about this. So you might get the CBC first. If they're 103 and to the point the kid is like not responding well, and go ahead and send them in to the ER. But if you think you're catching it early, get a white count, see where it is. If they're limping, they have fever, and then they have a high white count, you better go looking for a septic joint, okay? So these kids need IV antibiotics, okay? And they're gonna need an orthopedist, pediatric orthopedist to look at them. They may need to be washed out. The hip may need to be arthroscopically washed out or opened and washed out, depending on the age, depending on what the orthopedist is comfortable doing, okay? The solution to pollution is dilution, remember that? So, solution to pollution is dilution. So they've got a septic hip. What's one of the best things you can do for it? Wash it, dilute it, and then hammer them with antibiotics, okay? These kids probably, you know, I think there's probably a lot of 80-year-old people walking around with hip replacements that had a septic hip in 1925. You know, I would be curious to know, because they just survived it, you know, like they survived whooping cough and polio. You know, you either died or you survived it. And if you survived it, you had a bad hip. And then you get your hip replaced 50 years, 60 years later, you know. Just a thought. But we would see a lot of patients come in with AVN and you just don't even know why. They could have had a septic arthritis at some point. You never know. So by treating this early, detecting it, treating it, may take money out of an orthopedic surgeon's pocket someday. You may not get to replace that hip. Yes?
Is there ever more than one joint?
It's usually one. That's the other thing too. I mean, it's usually going to be one joint where the infection is seated. So that's a good diagnostic clue to look at. If they've got multiple joints involved, then it's probably inflammatory. It's probably inflammatory arthritis. We'll talk about that in a minute. That may be the next topic, actually. You know. And kids with multiple joint pains, they might feel bad, just not feel good, but they're not going to look septic. They're not going to look toxic. Okay. So this, again, used to be called juvenile rheumatoid arthritis. We call it juvenile idiopathic arthritis now. New name. If they've had joint pain lasting for greater than 6 weeks and they're less than 16 years old, it's JIA. You got to figure out what kind they have. Okay. They have a particularly involved joint, like they're coming in with the same knee that's swollen, you know, for the last 6 weeks. Get a fluid analysis of it and see what the balance is between the cell count. It is a diagnosis of exclusion, so you got to make sure it's not a toxic, you know, patient. It's not a septic joint. Make sure they don't have hip dysplasia, like Hepburn disease, all these other things we're talking about. You can get labs to help you out. If it's a swollen joint, they could have a bleeding disorder. It could be a hemarthrosis, which, okay, hematology, what's the most common one in kids, causes one joint to blow up. Who's the rock star today? Anyone? What'd you say? That's a good question. That's good. Like a factor VIII deficiency. Something that causes them to bleed into their joint. So they're going to be the big congenital bleeding disorders. But if you tap that knee, it's going to be full of blood, right? There's your answer. Okay, so I want you to know 3 types. Okay, so you've seen this patient. They've got ankle pain on their left ankle. They've got knee pain in their right knee. Sometimes their hands hurt. So they're not septic, they're afebrile. It's gone on more than 24 hours. Mom comes in because they've been complaining for a month. Their joints hurt, okay? Now you're going to start looking at JIA, okay? So 3 types. By far, the most common is oligoarticular. So you're going to have less than 4 joints involved. It might be, like I said, left ankle, right knee, maybe some hand joints. This one almost never, and I very rarely put never on a slide, but it never affects the hips. Okay? It's gonna be ankles, wrists, elbows, knees, things like that. You can check an ANA on this patient, it may or may not be positive. But the big take home on oligo is the uveitis. This is a systemic autoimmune inflammation of unknown reason. They call it idiopathics or idiots. Can't figure it out. But they will get uveitis as well in their eyes. They have to have an eye exam every 3 months. So these kids need to go. If you're suspecting this, and you check an ANA and it's positive, you drew fluid off the knee, it came back 50,000 white blood cell count, it's not infected. You're suspecting that they could have rheumatoid arthritis or JIA, you send them to a pediatric rheumatologist. Yes?
Does JIA necessarily mean that it will heal spontaneously into adulthood, or that just starts?
Yes, so both, okay? So oligo is the most common, and it's got a really good prognosis. Usually it goes away, okay? You start getting into polyarticular, so you've got more than 5 joints involved, and they're affecting more of those larger joints, hip, knee. Now you're looking at, this could be one that's going to persist into adulthood, okay? So what you want to think on polyarticular is it's symmetric, like both their knees are going to hurt, both their elbows are going to hurt. They might have hip pain with this one, okay? The interesting thing about this one is there's 2 different presentations. You can get this, what we used to call Still's disease, like you get this young presentation. Y'all talk about Still's disease? This young presentation, age 1 to 6, will happen, freaks the parents out, but it's actually got a really good prognosis. It's going to be RF negative, and it's going to go away, okay? But then this older presentation between, young adolescents, usually females, present, and they're probably doomed to have rheumatoid arthritis as they get older. It presents more like an adult, and it's going to persist into adulthood, okay? And almost, those patients are almost always female, okay? This is the one that we used to call Still's disease, okay? And I thought I added this to the slide, but these kids are sick. I mean, they're like some type of illness, and they'll spike fevers. They'll spike a fever and a rash will pop up, and then it'll go away. And then they'll spike a fever and a rash will pop up, and then it'll go away. And this will go on and on for weeks. This is equal between males and females. These kids will have other signs of things being inflamed. Their ferritin will be high, their CRP will be high, they might be anemic, their white count will be high. They don't look good, okay? So it'll be a little bit more obvious presentation. But this is just something to think about in a kid that's febrile and has had an intermittent fever. May not be some type of weird leukemia. It may be JIA, systemic. Okay. These kids actually can get pretty sick though. They can get liver failure, pericarditis. Get them to a specialist soon. Okay. So 3 types. Oligo, most common and better prognosis. Polyarticular, may or may not go away. If it's an older age female, it's a worse prognosis. They may keep their autoimmune disease as they grow older. And then systemic. Systemic, they're sick. I mean, it's like you're working up a fever and you figure out that it's JIA systemic. Okay? All right, so I would refer these to a pediatric rheumatologist, because they'll probably treat them with DMARDs, methotrexate, which has to be followed closely. They use Humira and Enbrel and things like that, injectables, but if it's oligo and they've got one joint involved, you can just treat the one sore joint and put steroid in it. Can't do that for very long, but it may make it go away and it'll be okay. But These kids need to be managed by a specialist. Okay? And maybe you'll work for that specialist someday, I don't know. All right, you want to take a quick break?